Good afternoon, everyone. Thank you for joining us this afternoon for a very exciting panel discussion. We will be talking about disparities in substance use disorder treatments. And so with us this afternoon, we have some speakers who I am sure you will enjoy every moment and learn quite a bit about what they have to say. So stay tuned, and I will first begin by introducing our first speaker. Join me in introducing David Barron, who is a professor of psychiatry and the provost and senior vice president of Western University of Health Sciences. Barron is also an emeritus professor at the University of Southern California, former deputy clinical director of the National Institute of Mental Health, and chair of the Department of Psychiatry at Temple University of Medicine. His presentation today for you will be racial and ethnic disparities in the use of medications for opioid use disorder and their effects on residential drug treatment outcomes in the US. Welcome, David Barron. David, over to you.
Well, thank you very much and welcome everyone. I'm going to try to share my screen and hopefully this will work out. While I'm trying to do that, I want to say by way of full disclosure, as a psychiatrist, it's very difficult to do anything in 10 to 12 minutes. We usually work on 45 to 50-minute hours, but I'll do my best and be respectful for the other excellent presenters today. So let me, hopefully my screen share will pop up. Well, it's, hopefully this is the whole screen. I'm hoping people can see that. So can I get maybe just a show of thumbs? Can people see this full screen? Excellent, excellent. So very quickly, and even though I live in Los Angeles, I'll use my Philly revved up voice to make sure we get through in time. So no one ever accuses me of being from Los Angeles as soon as I open my mouth. So what I want to talk about today is a study that I actually did with a couple of very distinguished colleagues when I was back at Temple University in Philadelphia. And these are GIS specialists who really, they're a really great group to work with, the geography information scientists. And what we did is we looked at racial and ethnic disparities in the use of medications for opioid use disorder, commonly called MAT, and the effects on residential drug treatment outcomes in the United States. And it was a large study, and I'm just going to give you kind of the 10-minute version of it. By way of disclosures, none of the authors, including myself, have any conflicts. No involvement with pharma. All of us have some level of NIH or federal grant funding. So basically, for those of you who need to catch up on your emails while I'm going through my presentation, I know we've all learned that fine task of multitasking. This whole presentation was based on this paper that was recently published. And it really goes through the data in great detail. And as you'll see, it was a fairly large study. So if you fall asleep or you lose connection and you're interested in what we have to say, it's all available in this paper that was published in Drug and Alcohol Dependence. And again, this will really highlight that data. So just by way of background, we all know there's a very long history of racial and ethnic inequities in healthcare, not only access, but outcomes in the US. And this is particularly true in the area of substance use disorders, although the good data is just now coming out, only because it wasn't studied particularly well until fairly recently. We know that Blacks and Hispanics, unfortunately, there's not even data in the Native American population. I've done some work with some of the reservations out here, and it's actually even worse in that population. But they suffer worse consequences of substance use disorders than whites. And by that, we're talking about greater involvement with the criminal justice system, a greater issue with stigma and other related health problems. And this has been well documented over the last couple of years as the United States and really around the world, but the United States is really dealing with some of these issues that we probably should have been dealing with a long time ago. In addition, while at the same time we're facing these greater barriers to access and utilization, they often have poorer outcomes, and this is pretty common. Now, one can say there are a lot of factors that go into this: economic issues, socio-demographics, a whole host of things. But what we were able to find on a large analysis of a big data set that was federally federally attained, was that they get less treatment, their outcomes to treatment are poor, and they get treated differently. And this is, I think, really the key to this whole symposium is how are we going to address this as healthcare, mental health care providers? Half of those who receive treatment for opioid use disorders in the US have done so in residential treatment programs. Now, residential treatment programs have some good things and some bad things about them. They've been around for a while. Unfortunately, the data does support that there is a risk of subsequent relapse with their substance use problems, the overdose is quite high. So they do offer some advantages, but there are some disadvantages that need to be addressed. Medications for opioid use disorders, MOUD, sometimes called MAT, medication-assisted treatments, are considered the gold standard for treatment. But it's important to understand that you're not really treating the disease. What they do is they lower risk profiles. So MAT, which is actually grossly underused. This is a big issue with NIDA. Nora Volkow, the head of NIDA, has had a lot of grants and a lot of interest in how do we get people to utilize MAT more, because it does save lives, even though it's not a cure per se. There really, even though there's a fair amount that's been looked at MAT or MOUD, very little research on the role in residential treatment settings, little research on outcomes in residential treatment settings, and there seems to be a pretty big variability across racial and ethnic groups, and that's what we found in our big data analysis. Blacks and Hispanics account for more than 20% of all publicly funded RTC admissions for opioid use disorder. So the methods of our paper, and again, if you want the details, please take a look at the paper, but we examine racial and ethnic disparities in the use of MOUD in both short-term, defined as 30 days or less, or long-term, greater than 30 days, residential treatment settings. There was an influence of racial and ethnicity on the use and treatment retention and completion. So it's important to look at how many patients actually stayed in treatment, and then how many people actually were full completion. So as you might imagine, there's a reasonably high dropout rate for a whole variety of reasons. So the outcome was really looking at how these medications might have had an impact on those two important clinical variables. The data was extracted from a SAMHSA data set, the TEDS data, which I'm sure many of you are familiar with, looking at adult opioid admissions and discharges. And again, we had fairly large ends, 83,000 plus for the short term, and about 61,000 for the longer term. So what do we really find? Well, for the entire sample, which combined all of the groups, that MOUD or MAT had an increase in treatment retention. So people who are on that tended to stay in treatment longer, and in completions in the short-term treatment. So this was interesting that it really only showed a big difference in completion in the less than 30-day treatment. In the longer day settings, it did have an increase in retention, but not in completion. And there's a lot of reasons that might be. For those of you who've worked in this area, there are a lot of factors that go into people being able to stay in a treatment program for other personal, not necessarily health or addiction related issues. And there was a reduced treatment completion. We think that was probably not the direct impact, and there's no data to support that it was related to the MOUD. Blacks and Hispanic patients were less likely to receive MOUD. And this is really an important point, because if we see that the data was really quite robust in demonstrating that this really does help in keeping people either in treatment or completing treatment, particularly in the short term, that these underrepresented minority groups, they just weren't getting it as frequently. Yet they benefit just as much as white patients in improving outcomes. So it wasn't that they weren't getting it because they didn't do as well. The data was quite clear they did just as well, sometimes even better, but they just weren't being prescribed it. And lots of speculation on why that might be. For the entire sample, only about 70% of the patients received MOUD. Again, this is the big pet peeve of Nora Volkow in NIDA. You know, why aren't more people using this when the data is pretty robust that it does have a beneficial effect in a variety of important outcome measures? Black patients were less likely to receive it compared to whites in short and long-term settings. And Hispanic patients compared to white patients, but they were less likely to receive it in the short-term setting, slightly more likely to receive it in the long-term setting. And we're not exactly sure why that was. Again, MOU increased long-term residential treatment retention for all of the groups. So again, the take-home message is these medications for everyone did show a beneficial effect, and yet we're fairly dramatically underutilized in a group that might have benefited even more than their Caucasian counterparts. So what were some of the conclusions from this? Well, implications for addressing racial and ethnic inequities in the public health response to the opioid crisis. It really underscores what we see in a lot of other areas of medicine, that we really need to address this and be very, I think, proactive. It's one thing to get the data and to demonstrate it. And I think the next step is, what do we do to correct it? And again, what we've seen is this data has been really amplified in COVID-19. Every day, including today, I get papers from colleagues or reports about what we've seen. We've seen a fairly significant increase in deaths during COVID from overdose. The majority of these are opioid overdoses. So this is a topic that is even more relevant than it was when we first started with this data set. Vast majority of minority patients with opioid use disorder did not receive any form of addiction treatment. So we're looking at how many got MOUD and how long they were in treatment. The reality is we need to be looking at those who have gotten no treatment. They've not been identified. Many of them end up in jail where they oftentimes don't get treatment as well. And they're much less likely, even when they're in treatment, to get treatment strategies, particularly MAT and other things that we know will be helpful. Improved access to MOUD in the short-term residential treatment is particularly critical. As we saw, the long-term, the dropout goes a little higher, but the data is really quite overwhelming that utilization of this for all patients, particularly focused on Hispanics, Blacks, and where they're in there, Native Americans, Asian Pacifics have been similar, although it's not been reported out as much, that they really need to get these. And there's very good evidence to demonstrate that this would enhance clinical outcomes for the patients, their family, and again, we know the societal costs of substance use disorders in a variety of other settings. Enhanced outcomes for Blacks and Hispanics is, again, well documented. And if you want to see more of the specific data, I refer you back to the original paper. Again, those who don't get it do much less worse. By it, I'm talking about MOUD or MAT. Those who don't get it, even if they're getting treatment, don't do as well. So if we're going to put them in a residential treatment where there is an opportunity to improve outcomes, why not make sure that they're getting all the treatment modalities? And again, MOUD is one piece of a much bigger puzzle. You know, there are a whole lot of other things, social services, you know, that's a whole nother 10-minute talk at least. But this is one important piece that needs to be factored into the overall treatment strategy. Again, I think we're just about out of time here. Again, things have been underutilized. So just some of the other issues that need to be addressed along with this, other important pieces of that puzzle, as it were, certainly poverty. We see a dramatic increase in poverty in whites compared to minorities in some of these areas. Living in or being engaged in violence, oftentimes patients with substance use disorder get involved either directly or indirectly in violence. They live in oftentimes challenging situations, whether they're homeless or in poverty areas where all these things become exacerbated. Housing and food insecurity has been well documented. Unemployment, discrimination, all these have been well documented, and many others, as we all know, as very important triggers for relapse. As we know, substance use disorder is a recurring disease. It's like diabetes. You know, it's not a, yeah, get it once, treat it, it's cured, and it goes away forever. These are recurrent diseases. Unfortunately, this has probably added to some of the stigma associated with diagnosing and treating patients with these disorders. Final take homes. So given these environmental risk factors, residential treatment centers provide a controlled and structured and protective therapeutic environment. Now, the key here is we have to make sure when the patient goes home that adequate aftercare has been arranged. I've seen this in my own practice, both in Philadelphia and in other academic centers I've been at inner city areas, that the patient gets better in a controlled setting, but then they're discharged to the same triggers and problems that led to some of their issues in the first place. So aftercare becomes very important, including the ongoing use of MOUD. We've already talked about some of the issues related to that, and residential treatments provide important infrastructure, and that infrastructure, both inpatient and after discharge from the RTC, is really important. The role of wraparound services, where there's day centers, where the patient is engaged in ongoing treatment, not only for their substance use, but the other areas that we just talked about. Suggests that overcoming the barriers is really a critical component. Again, the key for this whole seminar is promoting equity in American healthcare response to this unfortunately growing and lethal opioid crisis. Providing minority patients with greater access, treatment setting, really, I believe, and I think the data supports this, needs to be a national policy priority, not just something amongst healthcare and mental health care providers. And finally, I don't think I went too far over my time, but I want to thank all of you for hanging in there and listen to a Philly guy speed up his speech to try to make it through in the required amount of time. And I'm really looking forward to hearing from the other experts on the panel. Thanks so much. Be safe, wear your mask, and have a good day. Back to you.
Thank you, David, for that excellent presentation. And a reminder to you in the audience that you can pose your questions in the Q&A box or in the chat. And at the end, after all the presenters have presented to you, we will answer your questions. Moving right along to our next panelist, and it is Dr. Laura Henkhaus, and she's a postdoctoral scholar affiliated with the Department of Health Policy and Center for Child Health Policy at Vanderbilt University Medical Center, and with the Data Science Institute at Vanderbilt University. Her research focuses on measuring impacts of childhood circumstances and policy interventions on health and economic well-being over the life course, and examining disparities in healthcare receipt and measuring quality, especially for mental, behavioral, and children's developmental health. Presenting on the topic this afternoon, disparities in receipt of medications for opioid use disorder among pregnant women. Dr. Laura Henkhaus.
Thank you. So yes, I'm also speaking about disparities in receipt of medications for opioid use disorder, and specifically among pregnant people. And this is work joint with Melinda Bunton, Sarah Clark Henderson, Christine Lai, and Stephen Patrick. We want to note that we use data from the Tennessee Division of TennCare, which is Tennessee Medicaid, but the content of this presentation is solely my responsibility, does not imply that TennCare agrees or disagrees with any of this content. And we thank the Robert Wood Johnson Foundation and NIDA for funding. So medications for opioid use disorder are important for pregnant people, both for maternal and newborn health. Pregnant people are included in the increasing number of people affected through the opioid use disorder. So the number of maternal opioid-related diagnoses has increased, as well as the incidence of neonatal opioid withdrawal syndrome, which you may also hear about as NAS, neonatal abstinence syndrome. And medications for opioid use disorder are the clinically recommended treatment for opioid use disorder, including among pregnant people. And they're important to suppress craving and withdrawal symptoms to prevent relapse. They can reduce overdose death, and they're also really important for newborn health to reduce the risk of lost pregnancy and preterm birth. And there is prior literature demonstrating disparities in receipt of these medications. So there's known to be less access to these medications in rural areas. There is prior work on racial and ethnic disparities in Massachusetts showing that non-Hispanic Black and Hispanic pregnant people were less likely to have received these medications. And there's also differences by form of payment. So these, both by form of payment and pregnancy status, come from a secret shopper design by my colleague Stephen Patrick, and showing that when calling providers among the list of providers who have waivers who are able to prescribe these medications, when presenting as having Medicaid insurance, they're actually less likely to get a visit versus those saying they have private insurance. And then also when disclosing being pregnant, those people also were less likely to have to get an appointment with a provider of these medications. And disparities in receipt of these medications have implications for maternal and newborn health. And so what we do is, first we look descriptively at these newborn birth outcomes and family characteristics by type of maternal opioid use, so whether having received treatment or not. And then we also look, so among those maternal infant dyads, pairs in which there was, in which the pregnant person had opioid use disorder, we measure disparities in receipt of these medications by family sociodemographic characteristics, including race and ethnicity, considering how racism, including residential segregation and interpersonal racism, may impact receipt of medications. So our setting is Tennessee Medicaid. We're using Medicaid claims and administrative data, along with birth records from the Tennessee Department of Health to collect family characteristics. And our study cohort is all Medicaid covered deliveries in Tennessee in this period from 2009 to 2016. And we identify receipt of treatment as having received these medications, buprenorphine or methadone, for at least 14 days in the last 30 days of gestation. So I'll also note a restriction of our cohort is we require 30 days of continuous enrollment in Medicaid prior to delivery. And so we also identify opioid use disorder through diagnosis codes. So those who have a diagnosis but did not receive any of these medications. And then thirdly, as a proxy for illicit opioid use, we identify through newborn diagnoses of neonatal opioid withdrawal syndrome. So those, again, mother-infant pairs, and where we observe this diagnosis, but no medication treatment. And we use low-drip models to measure the associations between these family characteristics and whether the pregnant person had received medication. So we look by mom's age, education level, whether primary language was English or not, mom's race and ethnicity, whether paternity was recorded on the birth certificate, and whether the mom resided in a rural or urban county. And we also look at some intersections of these characteristics, considering how healthcare delivery, health communication that is received by the patient may differ by patient levels of education, literacy, and nativity status. And firstly, so again, our sample, this is almost 315,000 mother-infant pairs, and 4.2% were exposed to opioids through maternal use. So opioid exposure was prevalent, yet there were quite low rates of receipt of these medications. So among pregnant people with opioid use disorder, only 27.8% received medicated treatment, which again is the clinical recommendation for treatment of opioid use disorder. We observed that among those which did receive medication, there were lower rates of preterm birth and very preterm birth, while there were other differences in the groups that received and didn't receive treatment, which may contribute to birth outcomes, which is the point of this paper. And so what we saw was that there was quite inequitable receipt in these medications. Those in which the pregnant person had English as a primary language were much more likely to have received medications. Outright, these are odds ratios. Those in which paternity was recorded on the birth certificate were more likely to have received medications, as were those in which the mom had at least a high school degree, and when the mom was aged 26 to 34 versus younger age. Meanwhile, real residents were much less likely to have received these medications, and also non-Hispanic Black pregnant people with opioid use disorder versus their white peers were less likely to have received these medications. And studying the intersection of race and education, we see this persistent gap in that Black pregnant people were much less likely, about 20 percentage points less likely to have received medicated treatment versus non-Hispanic white pregnant people. So what I'm showing you here This is the predicted probability of receiving medications for opioid use disorder. This is by race, each bar, these are by racial ethnic groups. And on this left panel is for no high school degree, where you see this dark blue, non-Hispanic white, have higher rates than all other racial ethnic groups, where the gap is largest between Black and white groups. And then on the right, among those with a high school degree, you see rates lifted for these other non-white groups, but not for the non-Hispanic Black population, where there's still this 20 percentage point gap. So race alone predicting much lower rates of receipt of these medications. And so while in our paper, we document these disparities, there's other literature, a body of other literature explaining differences in explaining healthcare inequities, including in the space of medications for opioid use disorder. Residential segregation is one reason we see much higher rates of buprenorphine distribution in areas with the highest percentage of white residents. So this map of the US depicts residential segregation where darker colors are greater percentage of white residents, the darkest color being 89% or more. And you see here these graphs showing over time as distribution of these critical medications increase, that was disproportionately in these areas that were had the highest percentage of white residents. And there's also a large body of work describing and explaining impacts of interpersonal racism on healthcare receipt. And so work including using scores measuring clinician racial bias has shown these to be associated with poor levels of poor quality communication with patients, lower patient ratings of care, and particularly among Black patients. There's also a literature showing the value of racial concordance, as in a Black patient being able to receive care by a Black doctor. And work has shown when receiving care by a Black doctor, the Black patients were more likely to adhere to recommended preventive care visits. However, there is Black patients infrequently have the opportunity to receive care by a Black provider. So in urban areas, 70% of buprenorphine providers are white, and in rural areas, this rate is 85%. There's an urgent need to address these inequities in receipt of medications for opioid use disorder. For pregnant people, we saw antenatal opioid exposure was common. Many pregnant people with opioid use disorder were not receiving these critical treatments. And we observed inequitable receipt, so lower rates of receipt, in particular among those who were Black, Hispanic, had a primary language other than English, and resided in rural counties. And as I showed in the beginning, there's been work as well demonstrating these racial disparities in Massachusetts. So these findings aren't unique to Tennessee, which is our data setting, and addressing inequity should be a national priority. And then I'll defer discussion to group time of how to address these inequities. And I look forward to that discussion. And we'll end my share now. Thank you.
Thank you, Laura. Excellent presentation. And again, a reminder, if you have questions or you just want to chat, please use the Q&A button and the chat button that's on your screen. And at the end of the presentations, we will answer your questions, we'll address your chat, and we'll have a lively discussion. Moving along, our next presenter is Sean Hill. Sean is an East Harlem community activist and a co-founder of the Greater Harlem Coalition. Hill works for Fordham University as an instructional technologist for digital scholarship and a pedagogy where he supports students, faculty, research, and teaching. I welcome Sean Hill.
Great. Thank you very much. So I am one of the co-founders of the Greater Harlem Coalition, which is a collection of just over 100 faith-based organizations, not-for-profits, small businesses, and block associations. And we occupy the geography of what is commonly known as Harlem. We include West, Central, and East Harlem, from the Hudson River over to the Harlem River. If you know anything about Manhattan, these are community districts 9, 10, and 11. And the data that I'm going to be presenting today comes from a number of Freedom of Information Act FOIL requests that we made to OASAS. And we made those specifically from March 1st, 2019 until February 28th, 2020 for the obvious reasons. There's also some New York City open data in here, and we have a significant debt to the University of Richmond's Mapping Inequality Project, which gave us the data on redlining and the history of redlining in a digitized form. So just as a ground truth to get started, it's important to know that there are 69 opioid treatment programs in New York. 51 of those are unique locations, and we have 18 shared locations, meaning those are located in the same building, same facility, et cetera, but just different program licenses with OASIS. And one of the first questions as a geographer I asked myself was, what would a random and equitable distribution across space of these 69 treatment programs look like? And so dividing New York City up into zip codes and randomly assigning a number using randomizer.org, we could come up with, for example, these 69 points on a map. Every time you throw the dice, you'll get a slightly different distribution, but this is generally what you would expect to see in a random distribution on a spatial plane. What we found, however, is that the distribution, to the shock of no one in the audience, I'm sure, is not equitably distributed. The distribution in New York City is heavily concentrated in the Lower East Side, Western Chelsea, extremely so in Harlem and East Harlem, where I'm presenting from right now, the South Bronx and Central Bronx. And I'm sure looking at this map, you can also see what we have termed opioid treatment deserts, places within the city which do not have opioid treatment within a reasonable commuting distance. So the distribution is non-random, and the question came, could we then compare this distribution to redlining and the history of redlining in America and in New York in particular? So you may know that redlining was a project of the New Deal in the 1930s. Federal Home Office, loan corporations, something like that, officers mapped a significant portion of America, urban centers in particular, and assigned, based on what was supposed to have been housing stock, 4 categories. There were best, desirable, definitely declining, and hazardous. I have highlighted those last 2, definitely declining and hazardous, because those were the categories that were redlined in the sense that loans would not be forthcoming, mortgages were not available. And the practical consequence of this was that for neighborhoods that had Black residents in particular, although other racial groups were also equally discriminated against, but Black residents in particular literally saw 3 generations of generational wealth that they had slowly and tirefully accumulated since the Civil War wither and die. People could not get loans to put a new roof on a home. They couldn't get an extension to add another bedroom. They couldn't purchase or begin a new business. They couldn't buy extra stock to stock their small business. And this led for 30 years until the 1968 Fair Housing Act to an incredible decay of these centers that had been labeled as being definitely declining or hazardous. So what does that actually look like in terms of the space of New York City? This map, which you see here, which comes directly from University of Richmond, you'll see that Manhattan itself has the most redlined and most intensely redlined neighborhoods. You'll obviously see that Staten Island, for the reasons we can all conjure up, has the least amount of redlining going on there. And what was absolutely fascinating upon looking at this data and comparing it to opioid treatment programs is there is almost a perfect correspondence between 21st century opioid treatment programs and red line neighborhoods that were designated that way in 1938, over 80 years ago. So if I drill down and show you Manhattan in detail, I will note that this redlining was done on residential neighborhoods. So you will see gaps around the outside of the island, which were commercial or industrial ports. But the the opioid treatment programs that you see here almost follow perfectly the red line maps from 1938. What about the least red line borough, Staten Island? Well, that is very much a pattern of Swiss cheese here, and the only two small-scale opioid treatment programs are precisely located in red line districts that were evident on that map from 1938. All in all, 96% of all New York's OASIS licensed OTPs are located in definitely declining or hazardous neighborhoods in this 1938 map. I mean, just think about that. A map of 38 years, pardon me, what am I saying? Of 80 years ago has a 96% chance that a OTP will be located in that. That is unbelievable correspondence. So the question could be, well, maybe you have a spatial correspondence for addresses, but what about capacity? What about admissions? Maybe the vast majority of people are being sent to best, for example, neighborhoods. But in fact, what we find is exactly as you would expect, the vast majority of patients receiving substance use disorder treatment in the form of methadone primarily are being sent to neighborhoods that were redlined in 1938. So the correlation is there. The question is then why? Why are these facilities time and time and time again located in these kind of redlined neighborhoods? Well, OASIS and opioid treatment program providers have exploited the inexpensive commercial real estate because of decades of disinvestment and decay. They also exploit the weak political resistance that is often found in neighborhoods that were redlined, and they exploit the fractured social capital of people who are simply just trying to get by in life and do not have time to engage or to resist. There's also, of course, the larger cultural myth about communities of color and addiction. And there is a focus, we would argue, on data snapshots, looking at defining a community as being the community of people in treatment and not the broader community that actually houses these programs and facilities. The consequences are large OASIS licensed programs attract dealers who literally commute into Harlem and East Harlem and thrive on adjacent blocks. They find it very attractive to go to work in a community where there's a density of a large number of people who are vulnerable to perhaps relapsing or engaging in the illegal drug trade again. Redlined communities are further devastated by the commercial and residential cost of blight that occurs in the immediate neighborhood of these programs and facilities because of the drug sales and usage. Property values, on the other hand, are actually bolstered in wealthier and whiter communities nearby. So this process of locating in low-income communities of color does not just simply add to the deterioration and blight of those communities. It actually actively bolsters the property values, social capital, and other positive social metrics in wealthier and whiter neighborhoods. And lastly, although This is something which is intended to address a need. We find that these large methadone megacenters, they provide a kind of bureaucratic and economic utility, while they at the same time harm the fragile communities that they house. And so our argument within the Greater Harlem Coalition is that OASIS and the large OTP providers are performing structural racism under the guise of care. And the cycle that we see, and we have seen, and my neighbors who have lived here for generations have seen for year after year after year, is that programs are concentrated in red line districts. Dealers then commute in to sell at this location because of that concentration. Then the buyers who come from other neighborhoods who simply just want to buy something for that day, but are not in treatment, also commute into the community to purchase. Then OASIS, and we saw this at the 1 o'clock presentation about data, OASIS then points to the dealing, the using, and the overdosing that occurs in the confines of, or the neighborhoods that were redlined, and further justifies increasing the concentration of those programs and expanding the capacity of the programs there. So the collective agreement among the organizations and the neighbors that I represent is that OASIS must acknowledge their addiction, and we're using this term very specifically, to large methadone programs. We want OASIS to acknowledge that the overdose epidemic in Harlem is at least partly fueled by the dealers who thrive next to large OASIS methadone programs. And we want OASIS to consider ways in which it can atone for the decades-long opportunity, economic, and community health impacts that the oversaturation of OTPs, for example, or an example of medical redlining, has had on the adjacent communities. We believe that OASIS must acknowledge that overdose rates in redline communities is a symptom of large methadone program failure and not necessarily a call for increased capacity. And our ultimate goal, and I hope the goal for anyone who is attending this program, is that we want small scale, equitably distributed, community-based, and effective treatment programs located in all New York City neighborhoods, not simply those that 80 years ago were redlined through a racist policy of discriminating certain communities from others. And I will just simply end with my contact information here. I look forward to the conversations afterwards. And I want to point out that 1 year before the Fair Housing Act essentially eliminated redlining technically, we of course can talk about the actual echoes that remain, but 1 year before that, the words of Lou Reed and the Velvet Underground that talks specifically about a white individual leaving a wealthier neighborhood in Manhattan to travel up to my current neighborhood in order to purchase heroin. So that's it. I look forward to your comments, questions, and the conversation with my fellow presenters. Thank you very much.
Thank you, Sean. We're having some very thought-provoking presentations. So I know you have lots of questions and lots of thoughts on your minds. So please, as a reminder, put your Q&A in the Q&A box or in the chat, and we'll get to them at the end of the presentation. Now, our final presenter for the evening is Max Jordan Gumeni Tiako, who is a resident physician in the Department of Internal Medicine at Harvard Medical School's Brigham and Women's Hospital in Boston. Ngumi Tiako hosts and produces a podcast that's titled Flip the Script, and also writes about racism in medical education based on personal experiences and observations. This evening, he is presenting on addressing racial and socioeconomic disparities in access to medications for opioid use disorder amid COVID-19. Let us welcome Max Jordan Gumeni Tiako.
Thank you, Dr. Fletcher-Blake. Hi, everyone. Thank you for having me here. It is my pleasure. As she said, I am a resident physician here at the Brigham. So today I will not talk so much about my research, but sort of thinking about the future of treatment for opioid use disorder, given that everyone so far has sort of laid clear the evidence related to disparities in access to safe medication. My actual research in this arena is more so similar to one of our presenters earlier, more so related to perinatal disparities or rather disparities in treatment of perinatal opioid use disorder. So just briefly, I want to get us up to speed on what has been found since the pandemic started in 2020. So in several cities, studies as well as news reports have been highlighting the disproportionality with which Black men especially have been experiencing overdose, both sort of fatal and non-fatal overdoses. So it's reports from St. Louis, reports from Massachusetts, as well as Pennsylvania, where I was living at the beginning of the pandemic. So some colleagues of mine at Penn, for instance, found that there was a 60% increase in fatal overdoses during the first 3 months of the pandemic compared to those same months the year prior, while there was actually a significant 23% decrease in fatal overdoses among white individuals. Similarly, in St. Louis, they saw that opioid-related deaths among Black men went up by nearly 50%, while generally death in St. Louis had only gone up by 2%. And interestingly, during the COVID-19 surge, for instance, here in Boston, where I'm living, there was an increase in mental health and substance use disorder-related visits, primarily driven by telehealth, but this specific increase was only seen among white patients, whereas during that, and then during the partial reopening that sort of allowed people to come back into care in person, there was a decrease in such visits among Black and Hispanic patients. Now, when we talk about the pre-existing landscape, I think my colleagues on the panel have done a good job already of describing the disparities that exist in terms of racial segregation and access to methadone versus buprenorphine, which are 2 of the 3 FDA-approved treatments that for opioid use disorder, the 2 that are specifically associated with decreased risk of overdose and mortality. Over the years, as we've seen significant uptake of buprenorphine, this uptake has been more specific to individuals that are commercially insured and disproportionately so those who are white. And one of the reasons is providers tend to one of many reasons that providers do tend to discriminate against patients who, for instance, have active heroin use and those who are insured under Medicaid. So Helena Hansen, she's one of my mentors, she's a psychiatrist and anthropologist currently at UCLA and with an appointment at NYU as well, has long studied this sort of divide in access to methadone versus buprenorphine. And she calls it a 2-tiered system of biomedicalization of addiction. Philippe Bourgois in California as well has sort of described the way in which methadone clinics were wielded as a disciplining mechanism. And one of the evidence of that is that in a lot of studies following the installation of methadone clinics, the decrease in crime was sort of was used as a metric of success for methadone clinics. And at the same time, as buprenorphine became approved, we've seen that there have been regulatory barriers for people of color to access buprenorphine. So that sort of shaped the moment in which we are right now amid the pandemic. So a couple of things. So since the pandemic started, SAMHSA, the Substance Abuse, and I don't like using that term, Mental Health Administration, has sort of relaxed their policies on both take homes for methadone but they left implementation up to the states. And more specifically, and as everyone probably here knows, is people who are on methadone have typically to go to the clinic on a daily basis to pick up their prescription. SAMHSA early on during the beginning of the pandemic said, well, people are now allowed to get 14 to 28 day take home such that they don't have to come to the clinic daily. But then again, leaving implementation up to the states has sort of rendered individuals vulnerable, especially in those states where policies may not be as liberal regarding medications for opioid use disorder. Now, on the other hand, regarding buprenorphine, providers who prescribe buprenorphine have been, since the beginning of the pandemic, been able to use telemedicine to initiate and refill prescriptions for their patients. And for patients who were patients who were previously treated with buprenorphine. So there's thus sort of been a relative, I guess, less of a potential for people on buprenorphine to experience disruptions in their access to medications for opioid use disorder, while certain hurdles remain in place for those individuals who are on methadone, because even though take homes have been made more possible, people are still required to show up to methadone clinics for their initial appointments. Now, one might ask, how may treatment affect or further mediate socioeconomic disparities, the existing disparities we already see in the populations that are receiving treatment via methadone versus buprenorphine. One that doesn't get talked about nearly enough, I think, is the employability of individuals who are receiving one versus another form of therapy. And so, as a resident physician, I talk to patients who are on methadone, and I've also done research in the space. And so this is a quote from talking to a patient in the past who said, a big part of recovery is learning how to do your life. You can't do that when you're trying to devote all of your waking time to a clinic. You can't, and you can't even work. And so we know, for instance, people, for the most part, have to go to these clinics on the daily basis. Sometimes the lines are long. I remember walking by these lines when I was in medical school, incredibly long, patients having to wait, hours at a time. And that really limits the types of jobs that individuals are able to hold. And whether, for instance, if one day the line is too long, can they show up to work on time? Does that mean they're going to get fired? All that notwithstanding, the stigma around, around the fact that people have to, the stigma around the fact that people do, that some people do require such treatments to be able to function. And then, besides the issue of employability, the cost spent for each individual, the cost spent towards accessing treatment, besides the payment of the services that are provided, I think we need to further think about that, right? Going to a clinic every single day is costly, both in terms of the amount of time spent, but also what it takes for, in terms of transportation, be it public transportation or, single vehicle transportation. And that does not get talked about nearly enough. And in fact, there's a study that sort of compared the cost of going to a methadone clinic daily versus receiving buprenorphine on an outpatient basis, and has shown that in the long run, being a methadone patient, notwithstanding all the other components, ends up costing more to individuals. So, on the treatment side, in terms of solutions, certain things that are fairly evidence-based and have been proposed by many is that we need to liberalize access to methadone via pharmacies, and as well as integrating methadone treatment with primary care provision. In Canada, for instance, methadone is significantly more accessible and available through pharmacies. In the United States, especially for people who live in rural areas, it's, driving time to methadone clinics is a huge problem. And Paul Jodry at Yale has done a study to sort of simulated what it might be like if people in rural areas had access to methadone through pharmacies, and that would significantly reduce the amount of time spent just trying to get to a clinic. We also need to think about improving access to buprenorphine. I know most recently the X waiver, which used to be an 8-hour requirement, has been reduced to probably about under 1 hour. But buprenorphine still, though, remains the only medication for which, where there's like a specific indication where providers have to get a a sort of special certification in order to prescribe that medication for the indication, it being opioid use disorder, right? Because we can still prescribe buprenorphine for chronic pain or even acute pain. It's a great analgesic. But with no other condition do we as physicians have to actually sort of get special training to prescribe a given medication. And some argue, well, how else would you learn about it? Well, the solution is embedding addiction treatment in medical education, as we do with everything else. When a new diabetes drug comes on the market, we learn about it in school, we learn about it through continuing medical education. Yeah, and then we have to ensure that people who are newly diagnosed with opioid use disorder are offered the full range of first-line treatment options with shared decision-making, and especially for people with criminal justice histories, that court officers and folks who hold positions in the criminal justice system be educated on what are evidence-based first-line treatments, because currently evidence shows they tend to prescribe naltrexone, which in fact is not associated with longer survival or decreased mortality risk. And of course, beyond treatment, there's a significant component where race and class intersect here, and what it means in terms of the the medicalization of addiction, right? And so Helen Hansen and colleagues described that in the context of buprenorphine clinics, which otherwise have been described as like this sort of symbol of freedom, where you get to go to a clinic and get your medication, and no one really has to know that you're a patient with opioid use disorder, because it affords you that kind of privacy. They found that actually white patients who are on buprenorphine are best able to sort of capitalize on that medical focus and confidentiality of office-based buprenorphine therapy, but that Black and Latino low-income patients are experiencing a sort of isolation, right? Because medical treatment is not enough to address issues related to addiction. And that, I think, highlights the need to really address vast underlying disparities in resources that shape the experiences of people with addiction and people who are undergoing treatment for addiction, such as poverty, lack of housing, and community connectedness, as well as criminal justice histories. And I'll just highlight from my previous research, I think that sort of drives the point home, right? When I looked at pregnant patients over from 2013 to 2017, and their sort of odds or predictors of receiving both receiving medication and then also remaining in treatment, a lot of the predictors across racial groups, a lot of the negative predictors of both receiving medication and treatment were more so tied to socioeconomics, like unstable housing, unemployment, and criminal legal histories. And just to drive the point home, one of the last patients I saw in medical school, just this past year before I graduated, in the ICU, having experienced an overdose. When we mentioned, would you be interested in treatment for opioid use disorder? Her response to us was, I'm not interested in treatment. I don't think I even have addiction. I could stop tomorrow if I want, but you should try to sleep out there sober in 20-degree weather. And that really, those words really stuck with me, in that there's so much sort of trauma and suffering that sort of renders people incredibly vulnerable and makes them need in certain instances these substances in order to sustain themselves and even have hope in the first place. And with that, I will end here. Thank you everyone for listening.
Thank you very much. These discussions, these presentations are just very, I said it before, thought-provoking. And at this point, I think a lot of you in the audience have questions about why, how, where. So we're going to get to the Q&A and to the chat. So continue to put your questions there. And so I am going to read the first question, and I will direct it to the panelists. The first one said, disparities in access to MOUD are well documented. What policy solutions do you think would have the greatest impact on addressing inequalities? And Laura, I'm going to address it to you first.
Sure, yeah, and I think our previous presenter also made some important points on that, and what I would add, and so for one, an importance of people being able to receive care by someone that they believe will help them, and so there are some there can be some value in supports for providers and other allied health professionals, in particular from minoritized racial groups, to receive these trainings, whether as the providers prescribing these medications or peer recovery coaches. And there is some precedent for this in Boston. There's a project called Recover, which prioritizes Hispanic and Black peer recovery coaches for trainings, and whether that support, and then as a policy decision, is actually funding support for programs to expand trainings, in particular for minoritized providers.
Thank you. David, do you want to add to that question?
You here? Yeah, I think it's a great question, and I really appreciate, I think it was Sean's presentation, of what's going on in New York. So I started working in methadone maintenance programs in 1970, which makes me the oldest guy on this conference. And it was exactly the same, and that was in Philadelphia, in North Philly, not too far from Temple. I was still in high school, but I got involved in that because my dad and grandfather were involved with substance abuse treatment, both psychiatrists. And I think it really is a combination of legislation, of using the GIS science, and really all the things we talked about here, that it has to be a public policy issue. The data is there, but we've had the data for a long time. What are we going to do with the data? How are we going to operationalize it? So you can look, and I think anyone who follows this literature will say, and this is nothing new. I mean, again, we saw going back to 38 with the redlining, but certainly opioid addiction treatment, when I got involved very, very early in my life and my career in the 1970, things haven't changed a whole lot. I did a Fulbright up in Canada and went to Vancouver. And where do you see the big treatments where people can shoot up legally? They're all in the same neighborhoods. They're isolated, and it's like the rich get richer and the poor get poorer. So I really like and appreciated the comments that were presented, particularly Sean's and what's happening in New York. And I think this really has to be, and what I tried to emphasize, is a public policy, a public health issue, that we really have to look at this, not only from the medical and the data, which is there, but how do we operationalize this to really make a difference?
Thank you. Sean, you.
I would just reiterate that that's exactly correct, David. And what we require is actually bureaucratic bravery. We need the agencies, the providers, everyone from the intake nurse up to the head of OASIS to acknowledge the decades of data that we are talking about here that have been presented. As David has pointed out, this is not new knowledge. I mean, some of the things Laura has came out with, for example, was just wonderful to see, but the point is we've known this for a long time. The question is, how are we going to effect change within the organizations that we run? And the problem boils down, in our experience, to social capital, that very few providers want to go up against trying to put a methadone center in the Upper East Side, even if they could afford the real estate. They're unwilling to try to put one in the Upper West Side, into Bay Ridge, into Staten Island, because of the political firestorm and the social capital that will be employed against them as individuals, as employees, as administrators. And so it's just far easier to just allow the systems to unfold as they have for decades.
Thank you. Dr. Gomani-Tiako, you want to add anything to that question or that discussion?
Yeah, my main point similarly is that regarding generally access to medications, I think it's it's got to take pushing the federal government. A lot of the regulations around where, you know, who can prescribe methadone outpatient, who can prescribe methadone, even on, you know, like a short-term basis or for a bridge, like come from like federal regulations. That's the reason why. So in January, for instance, HHS announced that they were striking the X waiver, at least temporarily. And then they learned that they actually couldn't do that because of some, I don't know, some kind of federal rule. And they basically kind of needed to go through Congress. And so, you know, legislative advocacy, I mean, that's what I would say. It's, you know, we have to leverage all of our professional societies that are huge lobbies, but often tend to be sort of more focused on, I don't know, like payment reform, those kinds of things. Yeah.
Thank you. You touched on in your discussion the need for medical education to be more attuned to addiction and to start incorporating addiction services and into medical education, not just addiction services, but education about addiction and how to treat, et cetera, into medical education. Talk some more about how that can happen, because it seems to me as a medical provider myself who was not introduced to addiction medicine during my training, that could revolutionize some of the disparities that we are talking about here in terms of treatment. So what are your thoughts about how this can happen?
You know, I think there are multiple different pathways, like starting even how we're recruiting medical professionals. You know, stigma is a huge barrier, right? Besides even lack of education. For instance, there are providers, and this has been studied several times now. There are providers who would like to provide, say, buprenorphine in their practice, but they won't because of stigma from colleagues, stigma from staff in their own offices. So I think when I say education, it goes beyond what we're doing in medical school, but generally all health professionals. And so how are we selecting who is coming into the field? How are we thinking about like attitudes that people hold? And of course, those attitudes aren't static, but I think it's sort of like a going to the root cause, right? Like when we come into training, holding certain attitudes, are these attitudes that are malleable, that can be addressed? And then during medical training, making sure that it's really integrated as part of what we're doing. So for instance, when we talk about endocarditis, we should talk about some of the reasons why someone who is only 25 might end up with endocarditis, like injecting drugs. And I think it should be a requirement as much as it's a requirement to think about like blood sugar when you're admitting a patient. And so for me in medical school, for instance, during our capstone course, we had like an 8-hour, the capstone course is where it's like, okay, here are all the things you really need to know as an intern, so you don't like make us look like we didn't educate you. And so we had a long session where we're just making sure to sort of think about both pain and addiction. And it has to be reinforced. It has to be reinforced during residency. It has to be reinforced through continuing medical education. But yeah, I think addressing stigma is huge, and it needs to be done across professions. And just because someone brought this up in to the questions to panelists, this question of health professional shortages, and something else is leveraging APRNs and PAs. So for instance, in rural areas, the significant sort of bump in number of providers that are able to prescribe buprenorphine has come from what APPs, as people call them, advanced practice practitioners. So that is one of the ways we can sort of leverage other healthcare professionals and their help in providing medications for opioid use disorder. Similarly, midwives, I think there's still sort of barriers for midwives being able to prescribe these medications. And in a lot of rural America, peripartum care is provided by midwifery. Yeah.
David, you want to add to that?
Yeah, so just again, by way of full disclosure, I've been involved with medical education and health education for 40 years. At my current university, we have 9 graduate health colleges: nursing, PT, OT, medicine, dentistry. I require all of our students, all of our medical students had to go through it, and they were all wavered. They go to Indian reservations, which are very close to our university. We have a campus in East LA, and we have one up in Oregon. So the education is really important. We run a course called Interprofessional Education, where students from all of the 9 healthcare disciplines get together so they learn how they can work together, and we have standardized cases. And because I've been interested in addiction education, one of our standardized cases is actually an inner city addiction problem that really gets into all the issues. So the key, really, I think one of the keys is education, but not looking at this just as a physician issue. We engage a lot of primary care docs. I'm involved with a couple of big projects with WHO, looking at this in rural communities in low and middle income countries where they don't have psychiatrists, they don't even have doctors. So we're going in and training and using various techniques to get whoever is providing the health. Some of them don't even have the equivalent of what we would call a high school education. So education is a big part of it. It's not the only answer, but I think by education, we can start to address some of the stigma issues that Max just mentioned. We have to change the curriculum and change the paradigm. And I couldn't agree with him more that this has to be viewed as interprofessional collaboration. We just got a very large grant in our nursing school to train all of our nurses in the area of addiction, whether they go into a psych NP program, which we have at our school, or just general. Because I think we have to expand the net where people don't view like, well, only people interested in dealing with addicts get into this. No, this is a part of healthcare delivery. It's a public health crisis, not only in the United States, but internationally.
That's great. That sounds like a best practice. And so the question here is, there are several best practices. And as I hear the panelists and hear you and your colleagues discussed earlier, there are best practices that are in place or are emerging. How do we share these best practices? Because what you're doing just seems so phenomenal. But how do you bottle this and share it so that this peer learning, let's say, is spread throughout other parts of the country? You're muted, David.
Again, I'm probably the old graybeard on the group, but again, nothing new. It really starts with changing the culture. And I think that's what we've been talking about. The data is there. We're fighting socio-political issues, economic issues. You know, there's a whole host of things. Part of it is changing the culture that has led to the stigma and has led to all the things that all of the panelists spoke eloquently about. Changing the culture really has to start very early on. Medical school or graduate school is almost a little too late. We can make an impact, but this has to really go down. It has to be integrated into how we view addiction. That, you know, it's not a flaw in one's moral fiber, it's a disease. And there's a lot of work going out there understanding what's going on in the brain. So that's the first part. But then I think it's really looking into some of the really important work that was shared today. So changing the culture, getting good education, and then making this a political issue. So instead of making it politically expedient to keep them out of the high-end neighborhoods, is really flipping that paradigm. And that's not going to be easy. That's going to take a lot of work, because whether we like it or not, the stigma issue is very much alive and well. But it's going to take a concerted effort of education, of public policy, public health, and really getting everyone on board. I'm biased as an educator for a lot of my career, is that, you know, getting people early on to understand these are diseases like diabetes, like hypertension, like cardiovascular disease that have important biopsychosocial implications, and then start it's going to be a long-term strategy, but I think using the data and growing on that once we start to change the culture and the view of addictions, and recognizing that minorities have not been treated, whether it's where the clinics are, but in a whole host of areas like we've heard today. Until we do that, I don't see it changing. And I don't want to be pessimistic, but we have to be kind of proactive politically as well as education, and drive it earlier on, not just waiting till students are in medical school or in graduate nursing or other disciplines.
Thank you. This has been such a wonderful and inspiring and educational discussion, and I'm sure that everyone has learned something from this discussion, and if not learned something new, have now the ability to think outside the box and to think of some strategies and some ways that we can start addressing some of these disparities that have always existed. Your discussions have really pointed to some issues that we need to start paying closer attention to, and not just pay attention to, but start doing something. So there's a call to action here. And the call to action is we need to do something. We know it's there, data is there. Let's all work together and begin to brainstorm and to use the information that was presented here today and seek additional information, how we can all come together to make a difference and to start impacting some changes. With that, I will say thank you to the panelists. I'm going to turn it over to Patricia and ask her to close us out.
Thanks, Debbian. I think you just summed up not only this panel, but the entire conference in terms of what the point of the conference is and what we're really here to do. And I just want to say, I think these presentations all day have been great, but I wish we didn't need to have this conference. I wish that this particular topic weren't so relevant and such an important topic right now. But it is an important topic, and it is an issue that is getting worse. And so I want to thank all of the panelists and moderators and audience who joined us today. And we've heard from experts, and those are researchers, those are practitioners, and those are policymakers on a variety of drug policies and interventions that affect federal, state, and local government operations. And we've heard discussions about substance use disorder and harm reduction and efforts to make treatment effective within kind of a broader regulatory framework. And we've heard suggestions, very concrete suggestions about the things that need to change to do better and to make more progress. So our charge now is just what Debbian said, to take the lessons we have learned and translate them into policy and into practice to meet these broader challenges. And so Rob Kent and David Holgrave gave us some suggestions on how to do that, but the charge really is for us. And so we brought together policymakers and researchers and hope today's forum was not only insightful, but like Debbian suggested, kind of a catalyst for doing something more. And I just want to remind anybody that if you've missed any presentations today, or you wanted to rewatch some of the presentations, you can go to the Rockefeller Institute's website, www.rockins.org, and select past webinars under the events header. And all of the presentations will be available. I want to thank everybody who participated and the staff at the Rockefeller Institute of Government for staging this event and bringing everyone together for an insightful and a robust discussion. So thank you all.